I have the privilege of introducing Dr. Ijeoma Isiadinso. She is the co-director of this program with me, and she will be up in a little bit moderating, but we also asked her to be a speaker this year. She's very, very interested in fatty liver and its association with cardiovascular disease. She is the new director of the Emory Heart Disease Prevention Center, and she's a very valuable member of our Emory Women's Heart Center team. She's an associate professor of medicine at Emory. She did her undergraduate at Hahnemann which was previously called Drexel University, and then did her internship and fellowship at Temple University. She's very active with the American Heart Association. She's a speaker for them, but she's also on their health equity and multicultural initiatives. She's also interested in the power to end stroke through AHA. She has special interest in lipids, women and heart disease, and cardiorheumatology. She's an excellent teacher and clinician and was voted this year top doctor in Atlanta. We're very proud of her. Dr. Ijeoma Isiadinso.
Thank you very much, Dr. Lombard, for that introduction. I hope you all can hear me clearly. If not, you can just indicate via the chat. All right, so I am going to be talking about non-alcoholic fatty liver disease and cardiovascular risk. I have no disclosures. This is a general outline of my talk. I am going to try to stay within the limits of the 30 minutes for this talk so that we can have some time for questions. But this is a very, very broad topic. And as a result of that, there are some things that I will not be covering today, including some future therapies that are being investigated for the treatment of non-alcoholic fatty liver disease. And I've listed some of the drugs that are currently under investigation at this time. But I will be talking about the epidemiology of non-alcoholic fatty liver disease, the pathogenesis and the current hypothesis of the development of non-alcoholic fatty liver disease, associated cardiovascular risk, and the evidence that demonstrates that there is an increased cardiovascular risk among those who have non-alcoholic fatty liver disease and current treatment that is used in this population. So what is non-alcoholic fatty liver disease? Just a little information about the epidemiology. It is the most common cause of liver disease in the United States and in fact worldwide. It affects 25 to 40% of adults in the United States and 60 to 80% of obese and diabetic patients. This is data from the EUNOS Registry, which showed over a 5-year period ending in 2019. If you look at their etiology for liver disease resulting in patients being listed for liver transplantation in the United States, that at least back in 2014, and I don't know if you all can see the legend here, but I'll go through it, that previously it used to be hepatitis C virus was the leading cause of end-stage liver disease resulting in the need for liver transplantation. But that actually has been on the decline, and that is primarily through effective treatment of hepatitis C. And now what we're seeing is that the top 2 causes of liver disease resulting in patients being listed for liver transplant are Nash and alcoholic liver disease. When we break that down to look at individuals who have whether hepatocellular carcinoma and those who do not, what we see is that among those who do not have hepatocellular carcinoma, that the leading cause remains alcoholic liver disease, but right behind that is Nash. What I found most impressive is that the number of the prevalence of individuals who are, or the proportion of individuals rather, who are listed for liver transplant who have hepatocellular carcinoma due to hepatitis C is sharply declining, but very soon, and probably within the next less than 5 years, that they will be quickly overtaken by patients who have Nash. And so it is very important when we consider that our patients who are now developing worsening liver disease requiring liver transplant is due to non-alcoholic steatohepatitis. Non-alcoholic fatty liver disease is considered by many to be the hepatic component or equivalent of the metabolic syndrome, and that's because of some of the overlap with some of the criteria for the metabolic syndrome. It is important because the prevalence is rising quite rapidly in the United States, and that's because of the high prevalence of type 2 diabetes and obesity in the US population. I will talk a little bit about the different types of non-alcoholic fatty liver disease. The most benign form is fatty liver. So really this is just a spectrum of conditions that begin with fatty liver, and then the worst outcome would be cirrhosis. So fatty liver is just fatty infiltration of the liver that is also called simple steatosis. And usually these individuals who have a very benign course will not progress to having liver-related complications or end-stage liver disease. But in some individuals, they will progress to developing inflammation of the liver on top of the fatty liver, resulting in non-alcoholic steatohepatitis. And that's about 20% of individuals who will progress to developing Nash. And then it can continue where the patients will develop fibrosis and, of course, end-stage liver disease. But again, even this is a lower likelihood of progressing to cirrhosis, about 5% or so. So about 80% of individuals who have non-alcoholic fatty liver disease live sort of in this area, just fatty liver disease, fatty liver rather. As I mentioned, they're predominantly patients who have fatty liver. 5% of US adults are those who have Nash. And this is important because Nash is the single most common cause of liver transplant in women. And this is not entirely clear why that is the case, but I do have some more interesting information about non-alcoholic fatty liver disease in women as well. So we have to keep this in mind when we think about our female patients. Some of the risk factors for non-alcoholic fatty liver disease include obesity. Obese patients are 4 times more likely to develop non-alcoholic fatty liver disease. And if you were to do ultrasounds on the obese population, 2/3 of them would be found to have steatosis. Non-insulin dependent type 2 diabetes is another risk factor for non-alcoholic fatty liver disease, as is hyperlipidemia. 50% of individuals who have hyperlipidemia also have non-alcoholic fatty liver disease on ultrasound. And there are some genetic components that we don't have time to go into today, but certainly those play a role in the development of non-alcoholic fatty liver disease. As I mentioned, most patients are asymptomatic, and the actual trigger for suspecting non-alcoholic fatty liver disease, usually the first thing that brings us to our attention is the elevated transaminases on laboratory testing, alkaline phosphatase as well as hepatomegaly. And then we start trying to understand why these labs are abnormal, and we usually do ultrasound, which demonstrates fatty liver. Non-alcoholic fatty liver disease is the most common cause of abnormal liver tests among adults in the United States, not hepatitis. What do we know about the pathogenesis? Well, unfortunately, it's not really well understood. But the going hypothesis is that there are 2 hits that predispose individuals from developing normal liver or fatty liver and then progressing to non-alcoholic fatty liver disease, or specifically Nash or cirrhosis. The first hit actually occurs due to hyperinsulinemia, resulting in an increased lipolysis so that free fatty acids accumulate and undergo decreased oxidation, so that you have increased triglyceride accumulation in the liver. So this is the steatosis part. And it's thought that this initial process predisposes patients to then be susceptible to the second insult, which occurs in the background of either metabolic or oxidative stress. This results in increased secretion of pro-inflammatory cytokines, which then causes inflammation, necrosis, and fibrosis in the liver, so that they progress from simple fatty liver to steatohepatitis, so where you have that inflammation upon the background of just a fatty liver. The diagnosis of non-alcoholic fatty liver disease is made first and foremost, as I mentioned, based on elevated transaminases, and the ratio of AST to ALT is less than 1.0. If the ratio is greater than 1.0, you need to think about other causes of liver disease in that particular case. Alkaline phosphatase and elevated GGT also. By definition, you have to exclude any significant use of alcohol in these patients, and of course, exclude other causes of hepatic steatosis, such as Wilson's disease, drug-related complications that predispose or cause the hepatic steatosis in these patients. So once you've done all this, and at least your suspicions are raised that these patients may have non-alcoholic fatty liver disease. Then the next step, of course, is imaging. Liver biopsy is obviously the best diagnostic tool for diagnosing non-alcoholic fatty liver disease, but it's not undertaken very often. And that's because of the complications and invasive nature of the liver biopsy. Although it's the most sensitive and specific means for diagnosing non-alcoholic fatty liver disease, you truly could arrive at that same diagnosis using radiographic non-invasive testing. And so this is what's often employed, either a liver ultrasound, CT, or MRI. And these often will be able to adequately demonstrate hepatic steatosis. So once you have the abnormal labs, the appropriate history, and radiographic testing, that usually is sufficient to arrive at a diagnosis and focus your efforts on reducing cardiovascular risk factors, which we'll talk about later, and addressing some of the underlying predisposing features for these patients. There are some cases where a liver biopsy is important, and that's when you're trying to differentiate between non-alcoholic steatohepatitis and simple non-alcoholic fatty liver disease, because those are indistinguishable without a liver biopsy. As I mentioned, inflammation plays a role, the increased production of pro-inflammatory cytokines, and we know that this also fuels the cardiovascular process in these patients, and is primarily through endothelial dysfunction, altered vascular tone, and enhanced platelets activation, which also promotes atherosclerosis. This is a slide that summarizes the levels of inflammatory and procoagulant biomarkers in patients who had Nash in this particular study. And as you can see, looking at high sensitivity CRP, fibrinogen, and adenopectin, that first and foremost, that there are higher levels of these inflammatory and procoagulant biomarkers among the patients who have no Nash, so very little Nash, versus those who had advanced stages of fibrosis. Adenopectin is a hormone that's important in lipid and glucose metabolism, and so this actually decreases with increased fibrosis, also important in the development of Nash and steatohepatitis specifically. So worsening lower levels rather confers increased insulin resistance. So very important that this also correlates with worse stages of Nash, the lower the levels. This figure depicts the proposed mechanisms by which non-alcoholic fatty liver disease increases the risk of cardiovascular disease. As you can see, there are multiple pathways by which this happens. Endothelial dysfunction, which I mentioned, propagated by platelet activation, hyperhomocystinemia, and systemic inflammation. Altered lipid metabolism, which I'll go into a little bit further. Systemic inflammation in and of itself, so pro-inflammatory cytokines like IL-1, IL-6, high sensitivity CRP, plaque formation resulting in altered vascular tone, increased prothrombotic factors, oxidative stress, which I said again was also what you needed for that second hit to convert from simple steatosis to Nash, and systemic insulin resistance, which is at the crux of non-alcoholic fatty liver disease in these patients. So a very busy slide, but specifically shows multiple mechanisms by which non-alcoholic fatty liver disease is associated with increased cardiovascular risk. Dyslipidemia in non-alcoholic fatty liver disease is quite interesting in that these patients have a very pro-atherogenic lipid profile. So what you'll see in these patients is an increased apolipoprotein, lipoprotein B, high levels of triglyceride and LDL, low levels of HDL, and increased concentration of those small, dense LDL particles that can get into the into the coronary arteries and cause the development of plaque. These serum lipid profiles correlate significantly with the severity of non-alcoholic fatty liver disease. So just like I showed with the pro-inflammatory cytokines, that we see that you have a worse lipid profile, the worse or the more advanced the stage of non-alcoholic fatty liver disease. This slide summarizes what the findings are about non-alcoholic fatty liver disease in pregnancy. And I actually didn't know this before I prepared this talk, but it does make sense when we think about, again, the high prevalence of obesity in our population and why we see the rising numbers of non-alcoholic fatty liver disease in the population in the United States. And then over this 10-year period from 2007 to 2016, that non-alcoholic fatty liver disease has actually nearly tripled among pregnant women. And that was quite shocking to me. But part of that is because the largest rise was in our women of childbearing age, so under the age of 40. And then when they looked at women between the age of 20 to 39, about a third of those women were actually obese, obesity being a risk factor for non-alcoholic fatty liver disease. So it makes sense that as our childbearing women of childbearing age are becoming more and more obese, that the increased prevalence of non-alcoholic fatty disease is actually seen in that patient population as well. This is really important because not only is Nash an indication for higher rates of transplant in women, but more specifically including in I take that back. It's the most common indication for transplant in women just in general. This slide summarizes the complications of non-alcoholic fatty liver disease, both the maternal and perinatal outcomes. So we know that pregnancy, we consider that a stress test, and so that women who develop gestational diabetes or hypertensive complications like preeclampsia, eclampsia, are at risk for the future development of diabetes, hypertension, and even cardiovascular disease. Well, unfortunately, our pregnant women do not escape that risk who have non-alcoholic fatty liver disease. And we see that women who have non-alcoholic fatty liver disease compared to those who do not have higher rates of maternal complications, such as gestational diabetes, hypertension, eclampsia, preeclampsia, et cetera. And unfortunately, this risk also is transmitted to the fetus, and so they have higher rates of preterm birth and fetal growth restriction. You may wonder, what if these women already had diabetes and hypertension? Well, that would make sense in their particular case, and so is that a confounding factor? So they actually went back and adjusted for those underlying risks, such as pre-existing diabetes, dyslipidemia, obesity, and hypertension, and found that even after you adjusted for those conditions, that women who had non-alcoholic fatty liver disease had a threefold higher risk of hypertensive complications compared to those who did not have any form of chronic liver disease. And so I think this is really important because surely not only did I not know this, I usually talk to the patients about making sure that their ideal weight so they don't gain too much weight during their pregnancy, because we know that they may develop diabetes and hypertension. But I certainly did not know about some of these poor maternal outcomes as well as outcomes to the fetus as well, including preterm birth as well. So I think that we need to now consider with our women of childbearing age who have non-alcoholic fatty liver disease, that it's important to do some of that preconception counseling for them so that all of their risk factors are appropriately addressed if they're overweight, if the lipid panel is not a goal, that we discuss all of that, because as they plan to become pregnant, their risk increase, and at least making them aware of that increased risk during pregnancy. And so I think that we should be considering non-alcoholic fatty liver disease as a high-risk condition in pregnancy. And as I mentioned, it's important then to optimize those risk factors once identified for our pregnant women so that they can have a more successful and safe pregnancy. We talked about some of the increased cardiovascular disease that has been observed and the mechanisms by which non-alcoholic fatty liver disease confers that increased risk. And certainly that bears out when we even assess the risk using some of our available risk estimators. Patients with non-alcoholic fatty liver disease have a significantly higher 10-year risk for coronary heart disease compared with the general population, and that risk increases as the severity of disease increases as well. Patients with Nash have at least a 10% higher Framingham risk score compared to controls. And studies have demonstrated that this is independently related to increased risk even after treatment with liver transplantation. Part of this is the accelerated atherosclerosis seen in this patient population. And I think my next slide will talk about evidence of subclinical atherosclerosis in patients with non-alcoholic fatty liver disease. The mechanism for the accelerated atherosclerosis is one, chronic inflammation. We talked about the increased circulating pro-inflammatory cytokines, acute phase reactants, hypercoagulation, hypofibrinolysis, the pro-atherogenic lipid profile in these patients, and insulin resistance all play a role in the higher rates of earlier atherosclerosis seen in patients with non-alcoholic fatty liver disease. A number of studies have looked at the association between non-alcoholic fatty liver disease and cardiovascular events. So not only is it associated with increased risk, but we found that, or these studies actually demonstrated that patients who had non-alcoholic fatty liver disease were found to have higher risk of non-fatal and fatal cardiovascular events, independent of other risk factors such as advanced age, BMI, smoking status, history of diabetes, triglyceride level, etc. So certainly there is a direct association between non-alcoholic fatty liver disease and major adverse cardiovascular events that we should be aware of. Subclinical atherosclerosis, we know, is a marker for cardiovascular disease and is an opportunity for us to be very aggressive about cardiovascular risk factors once identified. Carotid intimal medial thickness is a surrogate marker for subclinical atherosclerosis. And in this study from 2010, we see that patients who had Nash had higher levels of intimal medial thickness when compared with controls, and of course, simple steatosis. The bottom slide shows more advancing levels of fibrosis or degrees of fibrosis among patients who have Nash. And just like we saw with the inflammatory cytokines in the previous slides, we see that patients who have progressive severity of non-alcoholic steatohepatitis have higher levels of intimal medial thickness, so greater degrees of atherosclerosis. Coronary artery calcification is another surrogate marker for cardiovascular disease and subclinical atherosclerosis. This particular study, they looked at coronary artery calcification development and progression as it related to the diagnosis of non-alcoholic fatty liver disease. And really what I want to draw your attention to is this bottom slide, and that's because what they found is that coronary artery calcification progression did not really correlate with non-alcoholic fatty liver disease, but it did correlate very closely with coronary artery calcification development. So those who had no coronary artery calcification, when they followed them over time, they found that patients who had non-alcoholic fatty liver disease, and more importantly, more advanced stages of non-alcoholic fatty liver disease, actually were more likely to develop coronary artery calcification over time, independent of the presence of other metabolic factors such as diabetes, obesity, and hypertension. It has also been found to be independently associated with aortic stenosis and mitral annular calcification. Interestingly, it's also associated with arrhythmias, specifically atrial fibrillation and ventricular arrhythmias such as non-sustained VT. In one study, they found that patients who wore a 24-hour monitor and were monitored for either non-sustained VT or heavy PVC burden, that patients who had non-alcoholic fatty liver disease had a higher prevalence of these arrhythmias compared to patients who did not. What do we know about treatment? Well, the cornerstone of treatment for non-alcoholic fatty liver disease is lifestyle management, and we'll talk about that a little bit more in detail. There are currently no approved pharmacologic agents specifically targeted to treat non-alcoholic fatty liver disease. There's a lot of treatment to treat, a lot of medications rather, to treat some of the metabolic factors that we identify, but not specifically targeting non-alcoholic fatty liver disease. That is all undergoing investigational trials. And liver transplantation is another treatment which we will not go into this morning just due to the time limitations. So the most important thing is to correct some of those metabolic risk factors through lifestyle changes, including weight loss, alcohol restriction, exercise in order to improve those risk factors such as glucose, insulin resistance, hypertension, obesity, hypertriglyceridemia. Interestingly, coffee consumption has been found to reduce the risk of fibrosis progression based on a meta-analysis of a number of observational studies. I don't know that this is really being recommended at this time, but it's an interesting finding. What about weight management? Well, studies have shown that weight reduction by at least 5% has been shown to improve steatosis and insulin levels among obese patients with non-alcoholic fatty liver disease. But what you would probably surmise is probably the greater the weight loss, the better gains you have. And it's true, you actually have very different findings. So while a greater than 5% reduction in weight will result in improved insulin levels and improved steatosis, if you were to have more than at least a 7% reduction in weight, these studies demonstrated that there was actually an improvement in the Nash histology. So when you did the biopsy, that Nash actually improved. And if you had at least a 10% weight loss, in fact, you could see regression of fibrosis, which is very exciting. So clearly we need to be focusing on dietary modification, exercise to promote weight loss. Although non-alcoholic fatty liver disease is not a specific indication for bariatric surgery, we know that patients can qualify for bariatric surgery for weight loss if they have a BMI greater than 35 with the presence of metabolic risk factors or metabolic complications, or if they have a BMI above 40, regardless of whether they have any additional comorbidities. Patients with Nash or advanced fibrosis who are then unresponsive to lifestyle intervention, at least some studies have shown at least trying for at least 6 months to achieve the appropriate weight loss goals, can then be referred to bariatric surgery, but not so much if they have cirrhosis, simply because there's a higher risk of perioperative complications. Studies have shown that post-surgery, so after bariatric surgery, that 80% of them will have resolution of Nash. So great improvement there. And again, reduction of fibrosis. And that's primarily driven by the weight loss. And as a result of that, you have improvements of the cardiovascular risk factors. So your hypertriglyceridemia, your hypertension, your diabetes. The 2012 Swedish study, which I've summarized here, demonstrated that bariatric surgery was associated with a reduction in cardiovascular deaths and cardiovascular events in obese patients. So we know not only does it improve your risk factors for cardiovascular disease, but it actually reduces major cardiovascular events. So bariatric surgery definitely should be on our radar if we have patients who are appropriate candidates for this for weight loss. What about alcohol use? We know that low to moderate alcohol consumption may confer some cardioprotective effects, but it's not really entirely clear whether that also translates to patients who have non-alcoholic fatty liver disease. So by definition, it's not excessive alcohol consumption in these individuals. So should we be recommending that they consume low to moderate amounts of alcohol? Well, we do know that heavy alcohol use is certainly associated with disease progression among patients with non-alcoholic fatty liver disease. And currently, in the absence of definitive data that is cardioprotective in these individuals, it's probably best just to recommend that they do not drink any alcohol at all. What about aspirin? Unfortunately, there's very limited data on aspirin use in non-alcoholic fatty liver disease. Most of the literature is limited to cross-sectional studies. However, there was one very recent prospective cohort study that examined 361 adults who had biopsy-proven non-alcoholic fatty liver disease, and 151 of those took aspirin on a daily basis. And they actually found that those who took daily aspirin had a lower probability of progressing to higher levels or more severe fibrosis or non-alcoholic steatohepatitis if they were on daily aspirin. The jury is still out on that, so it's not something that is universally recommended, but certainly if your patient has an indication of aspirin for other reasons, there is an additional benefit in regression of fibrosis in this patient population. What about statins? There often is some concern about giving statins to patients who have non-alcoholic fatty liver disease simply because at baseline their transaminases are elevated, but they are definitely safe to use in patients who have non-alcoholic fatty liver disease, even if their transaminases are up to 3 times the upper limits of normal. And we should definitely be considering giving this, strongly considering giving this to patients who have non-alcoholic fatty liver disease, especially if they have high cardiovascular risk. There was one post hoc analysis that actually showed that some liver enzymes may actually improve when you prescribe statins to this patient population. The only time you should certainly be concerned is not giving it to patients who have decompensated cirrhosis. Reninangiotensin inhibitors have been used in non-alcoholic fatty liver disease patients who have hypertension, and that's primarily because there's an increased prevalence of diabetes, hypertension, and kidney disease in this patient population, and it has actually been found to reduce liver fibrosis and liver enzymes when used in patients who have hypertension and non-alcoholic fatty liver disease. And the thought process is because there is a role for renin-angiotensin system activation in insulin sensitivity and fibrosis. And so use of the renin-angiotensin inhibitors causes regression of fibrosis that we see in these patients. Vitamin E has also been controversial. The role of vitamin E has been determined to be important simply because of the oxidative stress that I mentioned, again, that causes the progression from simple steatosis to non-alcoholic steatohepatitis. And that oxidative stress contributes to that progression. And so if you can give an antioxidant, perhaps you can reverse that process. There was a meta-analysis that included 3 trials analyzing the use of vitamin E at various doses ranging from 800 international units to 1200 in patients who had Nash. And they actually found that it did improve their liver histology. So you saw decreasing amounts of inflammation, steatosis, and ballooning, but not an improvement in fibrosis. The other thing is that most of these trials that showed a benefit with the use of vitamin E did not include diabetic patients, so you can't extrapolate these findings to that patient population. However, we know that vitamin E does not confer any cardiovascular benefits, and so we should not be giving them to patients for cardiovascular disease prevention if you're considering your patient who has non-alcoholic fatty liver disease, trying to reduce cardiovascular events. But if you're using it solely for the regression of fibrosis and advanced Nash, then it is something worth considering. There are 2 patient populations where you wouldn't want to give it, and that's patients who have prostate cancer because there's an association between high dose vitamin E, anything above 400 is considered high dose, and prostate cancer, and intracranial hemorrhage is another patient population. Insulin sensitizers, I'm gonna wrap up here, see I'm getting close on time. Insulin sensitizers are important since insulin resistance is part of the mechanism of non-alcoholic steatohepatitis. Metformin, we know, is a first-line therapy for type 2 diabetes. It improves insulin resistance, reduces transaminases in patients who have Nash and non-alcoholic fatty liver disease. However, it does not improve the histological damage seen in these patients. It also, one of the benefits is that it actually protects against the development of hepatocellular cancer. So while it will not improve fibrosis, we know that there is some benefit there. So it remains first-line therapy for patients who have Nash and diabetes. Some of the newer agents that have shown benefit is the pioglitazone, which is a peroxisome proliferator activated receptor agonist. In patients who have Nash, it was shown to decrease hepatic fat content, decrease ALT levels, improve fibrosis and inflammation, and in some cases, demonstrate complete resolution of Nash. The lyraglutide is a glucagon-like peptide agonist. This has been very exciting lately, especially because of its cardiovascular benefits. There are two studies that I'm going to highlight here, the first being the LEAN trial. In this trial, patients who had type 2 diabetes but were still not treated to goal despite being on more than one agent, including metformin. So they had hemoglobin A1Cs greater than 7. They were treated with liraglutide for 6 months. And as you can see, there was a decrease in the liver fat content. But more importantly, this is primarily driven by weight loss, so decrease in body weight. The LEADER trial, again, enrolled patients, about 9,000 patients in this particular trial, and they looked at cardiovascular events in patients who were treated with liraglutide. And you can see that there was lower cardiovascular events in the treatment group compared to the placebo. This primary outcome was death from cardiovascular causes, non-fatal stroke, and myocardial infarction. And when you look at each one of these, of the composites outcome here individually, you see that certainly there was a decrease in cardiovascular deaths in patients who were treated with liraglutide. Although there was a decrease in non-fatal MI and non-fatal stroke, those were not really statistically significant. There was also lower rates of heart failure hospitalization for patients who had cardiovascular disease who were treated with liraglutide. So definitely the cardiovascular benefits, and then as I mentioned in the previous slide, the regression of fibrosis. So in summary, non-alcoholic fatty liver disease is a spectrum of disorders that begins with simple steatosis, but can go to as severe as cirrhosis in some patients. Is considered the hepatic manifestation of the metabolic syndrome. There's certainly some overlap there with dyslipidemia, obesity, and hypertriglyceridemia, atherosclerosis as well. Cardiovascular disease is the leading cause of death in non-alcoholic fatty liver disease patients. We know that there's higher maternal and fetal outcomes in patients who have non-alcoholic fatty liver disease during pregnancy. It's important to focus on aggressive lifestyle changes, weight loss, so certainly improving some of these outcomes because of a reduction in cardiovascular risk factors. Tobacco cessation, which I didn't get into, is especially important, not just because of cardiovascular benefit, but also because tobacco use is linked to progression of fibrosis. So with that, I will stop and take questions.
Thank you so much, Dr. Isiadinso. We had several questions on statins, metformin, and vitamin E, which you somewhat answered. If you want to give one or two more comments on this. So these are the medication uses.
Yeah, so again, statins, I think I see that quite often. In fact, I saw that about 2 to 3 weeks ago where a patient was on a statin and told me that her primary care physician and she had an outside cardiologist stopped her statin because her liver enzymes were mildly elevated. And she clearly told me, well, I've been told that I have fatty liver disease. And so I went through the education of what fatty liver disease is and how statins can improve, first of all, her cardiovascular risk, and how it would not cause her any harm with those low levels of transaminases. And she was very open to that, and so we were able to get her right back on her statin. But I think that we should keep that in mind for those who have non-alcoholic fatty liver disease, who have dyslipidemia, who maybe have high cardiovascular risk. We should not withhold statin use in that patient population.
Also, several questions on the importance of diet, and you did touch on that. Do you have a few more comments on the importance of diet?
Yeah, I think that we probably underutilize nutrition services, and part of that is just because it's really not covered. Consultation with nutrition services is not covered except for certain diagnoses like organ transplant, diabetes, and so a lot of patients have to pay out of pocket. But I often refer my patients to a nutritionist just to give them some guidance when it comes to weight loss, because it really depends on sort of your activity level. Sometimes it depends also on cultural eating plans. That may be a barrier for patients, but a low carbohydrate diet really focused on weight loss is especially important to see some of those gains that we saw as far as cardiovascular risk factors and improvement in Nash seen in patients.
And is it the Mediterranean or DASH diet, a plant-based diet that you recommend?
Yeah, I mean, certainly starting with low carbohydrates, but I think I personally like to recommend a Mediterranean diet. I think that it has some great benefits. It's easy to incorporate in different types of eating plans. And I haven't really had any pushback from any patients saying it's something that they couldn't follow.
Wonderful. Well, thank you so much, Dr. Isiadinso, for this excellent lecture. And now we're all more enlightened about fatty liver and its risk. I do want to take a minute to remind you all to please visit the vendors. This would not be possible without them, and so we want you to visit Amgen, Janssen, AstraZeneca, Novo Nordisk Obesity, and Aspirin. Also, I've noticed that many of you are out there tweeting about the event. Our hashtag is hashtag EWHC20. Most of our speakers are also on Twitter, and you can do live tweeting. I've also gotten several emails from people who want to know if this is going to be on the CME website later, and yes, it can be watched in its entirety again, probably check back in about 10 to 14 days.